Our next speaker, he's an off-pump surgeon, so he doesn't really move that fast, but he's going to make it eventually. And so Dr. Devinder Bhatia is with Southeast Texas Cardiovascular. I had to get that right. Specializing in off-pump inadequate surgery. I mean, good surgery. And he's going to be talking to us about, all this stuff about the imaging. That's really cool, but what's the outcome of it? So how do you validate all that stuff that you did? How do you validate the efficacy of that? So they're getting his thing up, and then after this, during the panel, we're gonna get your phones out. I was asked by Roger to get you guys to subscribe to the YouTube channel. Don't forget to do that. It's the New Orleans Conference Las Vegas on YouTube. Make sure you subscribe to it. And I think our first poll for our online folks is going to be an open-ended kind of question. So it'll just say questions, and you can literally type a question, and then we'll see them come over, and we'll select those best ones. I got a call from somebody today wanted us to do that. We haven't done it up to this point, so we will do that. Dr. Bhatia.
Thank you, Joe. And I'm using this talk as my warm-up for our debate later this afternoon, Joe, on off-pump heart surgery. Well, I was asked to give a talk today on graft assessment using transit time flow measurement or ultrasound evaluation of coronary artery bypass grafts. And the question that one would ask is, why do we evaluate these grafts? We take patients to the operating room and we do multiple bypasses, and up until now we've had very archaic ways of assessing whether or not those bypass grafts that we put on the heart are patent. And so in the current state of affairs right now, about 70% quality control of some sort to assess coronary artery bypass grafts by ultrasound. Is it inexpensive? Yes. Is it convenient? Yes. But the correlation to quantity and quality of blood flow right now is questionable at best. So what is the rationale for graft assessment? Obviously, what we ultimately want is good graft patency. And the way that we would do this is we obviously want to improve our patient outcomes. We would like to have this as standardized level of care. These are predictive of our outcomes. We would protect our network referral. It gives us peace of mind. Once we know that these bypass grafts that we put on the heart are patent, I can sleep at night. It also gives us good documentation for our peers and staff, as well as the insurance, and it gives good instructions for surgeons in training. I've had, on the rare occasion when a graft would go down, at least you have the documentation at the time of the operation where the graft was fully patent and had good flow. So the rationale for graft assessment, even though the majority of cardiac surgeons are happy with less than 3% coronary artery bypass grafting mortality rates, patients are looking for relief of chest pain and the hope of no additional intervention. The prevention of additional intervention represents benefit to payers, including Medicare, private insurance, and society. And there was a Medicare data project done to track whether or not, to see how many patients underwent percutaneous coronary intervention after bypass. And they looked at billing quarters, over 8 quarters from 2007 and 2008. And what you can see is that as time went on, the level of intervention went up. So in first quarter 1, 2007, reintervention was 3.2. The next 4 quarters was 5.47, and later it was as high as 8%. What is the cost of reintervention? We take these patients to the operating room, we do their bypass surgery, and we hope that that is the end of the treatment plan for these patients. However, if they have to be reoperated on, we know it's very expensive. We know that there are multiple DRG codes for percutaneous coronary intervention with drug-eluting stents. They range anywhere from $8,000 to $16,000, and of course, reoperative heart surgery can run into several $100,000. And the cost of complications, we know that the mortality is increased, the non-fatal morbidity increases hospital costs by 200%, increased hospital costs and mortality up 236%. So the prevalence of abnormal grafts in a study done by Herman, the study showed out of 985 patients, both undergoing arterial and venous bypass grafts, 19% of the patients were found to have abnormal grafts. That's very high. What's the relationship between abnormal grafts and mortality? We know that poorly functioning bypass grafts are known to be associated with postoperative morbidity and mortality. Wyman reported that 54% of the 223 patients who died early after undergoing coronary artery bypass grafts had gross technical problems in the bypasses. They were unrecognized twists, conduits, stenotic anastomoses, and dissections. So transit time flow measurement is a cost-effective and safe and easy-to-use method to assess graft patency. What is it? It's a technology that gives you accurate and quantitative real-time flow measurements based on the difference between upstream and downstream ultrasound transit times. It's been tested, it's reliable, it's independent of vessel cross-sectional areas. Now, the way that this works is you measure a pulsatility index, mean flow, diastolic filling, and the waveform, which you can see in the lower middle portion of the screen. There are a wide range of probes depending upon the diameter of the conduit that is placed during surgery. And the feedback on the graft functionality is immediate. So for after undergoing bypass, you can measure these flows immediately, and you can see on the waveforms well-functioning bypasses in the upper center, and then ones that have problems in the lower center and in the lower right after it's been fixed, and I'll get into that in just a minute. But the triangle of coronary graft patency includes a good pulsatility index, which is usually less than 5, a good mean flow, and a high diastolic filling pressure. So how do we interpret these data waveforms in the operating room? Well, as mentioned, is there a pointer here? Yeah. You can see that we pay attention to the flow rates, we pay attention to the pulsatility index, as well as the diastolic filling, and then lastly the ACI, which is basically a coupling index, which tells you how well the vein or the mammary artery is opposed to the probe itself. What is normal? So for an anterolateral wall, for a mammary to LAD bypass, you want mean flows of anywhere from 30 to 50, a pulsatility index of, take as low as possible, but between 2 and 4 is acceptable. Anything less than 5 is clearly desired. And diastolic fillings of 70% or higher. So without getting into too much of the physics, if you have a vein graft here to the circumflex, you want mean flows in the 30 to 50 range, pulsatility index again in the 2 to 4 range, and diastolic filling in the 50 to 70% filling. Another example of a right mammary to the right coronary, and another example of a vein graft to the right coronary artery. So after looking at all these, tables have been developed that really show normal values for patent grafts and what we should be looking for in the operating room after completing these bypasses. Again, as mentioned, pulsatility index less than 5, diastolic filling greater than 50%, and flow rates, as you can see on the right side of the screen. So again, to summarize what is normal, left heart versus right heart, filling pattern on the left is diastolic dominant, and filling pattern on the right is a balance between systolic and diastolic. So what do we want when we see these in the operating room? We want to see a coupling index in the green. We want good predictable waveforms, little retrograde flow, again, pulsatility index, diastolic filling, and flows greater than 15. You should always be suspicious of flow rates, any flow rate less than 15 mils per minute, and a high retrograde flow greater than 3%. We can assess for competitive flow by occluding the native vessel proximal to the anastomosis. And if that is, in fact, what's going on, you'll see graft flow increase and pulsatility index decrease. What is pulsatility index? Well, it's a maximum flow minus minimum flow over mean flow. It's a good indication of graft and runoff bed resistance, and it's an independent indicator for graft longevity. What's clinically acceptable, again, I'm going to say we harp on the fact that we want a pulsatility index less than 5, and better than 3 or is even better, lower than 3. Diastolic filling, always greater than 50% in the coronaries. It's more balanced with systolic filling on the right side of the heart and diastolic filling 50%. On the left side of the heart, filling pattern is predominantly diastolic, 70% plus or minus. Now that we've talked about what's normal, how do we spot a bad graft, a bad bypass? Well, this is an example of an occluded mammary to diagonal, where you have a very low flow rate in the upper left corner of that graft, a high pulsatility index in the upper right corner, upper right portion of the graft, and a low diastolic filling. And they have this flow wizard that I don't use, but I guess it basically gives you what the normal should look like. And so we talked about these things here, and again, an occluded mammary to LAD and a revised mammary to LAD. You can see on the left side of the screen, you have low flow and a high pulsatility index. And after revising the graft, you now have a high flow or normal flow of 49, a low pulsatility index, and a good diastolic filling. In a kinked graft, you can see again low flow, high pulsatility index, and low diastolic filling. And after unkinking the graft, you can see correction in the waveforms. So to summarize for bad grafts, it's the patency triangle of low flow rate, high pulsatility index, and low diastolic filling. If you have those three or any of those three, you need to investigate what's going on with the bypass graft. So what do we do if we spot a bad graft? Well, first check for the easy things that you can fix. You always want to make sure that the acoustic coupling index should be in the green, and that's something that shows on the screen when you're measuring the bypass graft. You want your mean arterial pressure about 80. In low flow rate or low pressure, you will obviously have lower flow rates in the bypass grafts. You do not want to place the probe on a curve of a bypass or near a proximal anastomosis. And the probe size has to be correct. It has to measure appropriately for the diameter of the bypass graft. Again, the easy stuff, check for spasm, kinks, twists, and lengths. And then what are the things that we can do once we determine one of these things is going on in the operating room? Well, again, we mentioned if there's a low mean arterial pressure, we can ask our anesthesiologist to help raise the blood pressure. We can recheck and remeasure on some of these if I suspect that the bypass grafts have been done well and there could be spasm. You can always come back and reassess the graft after a few moments in time. Also, if you have competitive flow rates, you can occlude the native coronary above, and you will see that the flow rates and the pulsatility index goes down. If none of the above work, then you should consider kinks, twists, dissections, or even, surprisingly, a technical issue. And so there have been times, and I want to get to, I'm running out of time, where if it's not easy and the systolic filling is an indication of good proximal anastomosis, greater than 90% of the anastomotic problems are technical and they're at the toe and the graft should be redone. Blockage is usually seen as a high pulsatility index, a low flow, and mostly systolic filling. So there's been multiple papers that have been published and looked into this, and I will quickly summarize. In a study by Kaiser, in the Journal of Cardiothoracic Surgery back in 2010. They looked at 336 patients and came up with a conclusion that intraoperative flow of measurements of arterial CABG should become standard of care. If you have a higher pulsatility index, you have a higher incidence of morbidity and mortality. Also, a study done by Bhatia, again, European Journal of Cardiothoracic Surgery in 2007, intraoperative flow detection of graft dysfunction improves the surgical results. Obviously, if we detect a bad graft and we can do something about it at the time of the operation, we can certainly improve the patient's outcome post-operatively. Also, a study by Bauer in 2005, thoracic and cardiovascular surgery, again looking at a large group of patients that were done coronary artery bypass grafts. Routine use of intraoperative flow reduced technical complications for bypass surgery and leads to a significant reduction in mortality. One last study, D'Ancona and the European Journal of Cardiothoracic Surgery concluded that thoracic flow measurement or transit time flow measurement can reliably detect technical graft errors, indicate prompt revision, and improve post-operative outcomes. From the European Journal of Cardiovascular Surgery, graft flow measurement related to graft type, vessel size, degree of stenosis, quality of outflow area is useful at the end of surgery. Again, if we get the appropriate flows that we're looking for, or if you get flows that are not acceptable, it should mandate graft revision before leaving the operating room. Well, let me give you an example of expected results versus unexpected results. This was a case where there was a very gifted local cardiothoracic surgeon who did a single vessel bypass off pump mammary to LAD with no surgical complications. Clinical observations were normal. The patient had no hemodynamic instability. The transesophageal echocardiogram looked normal, and the palpation of the graft was pulsatile. So the conclusion was the graft was patent. And when we went to use the Medistim probe, we could see that the flow rate was very low. The pulsatility index was extremely high at 29.4, and diastolic filling was very low. So I revised it. This was my case. And I took the anastomosis down, and I redid it, and this is what we saw afterwards, a flow rate of almost 30 with a pulsatility index of 2.4 and a good diastolic filling. But the point of this is that in a situation where you feel that you have done the best job that you can, why would you leave the operating room without looking at this and being able to intervene? Because clinically, right here, the patient had no hemodynamic instability, no ST segment elevation, the TEE looked normal, and palpating a mammary artery that's anastomosed to a heart tells you nothing. It could be hitting a wall and not going anywhere. And so this was revised, and I was very happy because this would have closed down within a day or two. So about 90% of the time, this technology simply just confirms clinical observations. I think most surgeons would say they would sleep better knowing that in the 10% of the time that they find something or less, even if it's just once that they can fix in the operating room, it's well worth the 5 or 6 minutes that it takes to do this in the operating room. So I will just close by saying Dr. Lumsden has mentioned for transcranial Doppler that if he has heart surgery that they better be doing that on his brain. And I will say that if I have heart surgery, I would expect this technology to be done before the conclusion of the operation. Thank you guys very much.